I'm Dr. Gillian Goddard. I'm an endocrinologist and the author of The Savvy Patient. And today is our monthly Ask Me Anything. So feel free to ask any of the questions that you might have about women's hormonal health. As I mentioned, it's been a little while since we have done an Ask Me Anything because of the holidays at the end of last month. And many of you sent questions ahead of time. But you can also put your questions below in the messages. And I will get to as many as I can. I'm so excited to be back answering these questions. We have some good ones that are kind of new and different. The first question I wanted to answer, which was just sort of a quick question related to the conversation that I had earlier this month. If you weren't able to join us, I had a fantastic conversation with Marissa Renee Lee, who is an author. And we talked a lot about premature ovarian insufficiency, which is used to be called premature menopause. Essentially, it is having your last menstrual period before age 40. Um, and a couple of questions came out of that related to the timing of hormone replacement therapy and how to think about hormone replacement therapy in that particular setting. You all have heard me say that the best reason to start hormone replacement therapy is because you are having perimenopausal symptoms. And while that is generally true for most people, for women with premature ovarian insufficiency, our recommendations around hormone therapy are a little bit different. And a couple of you asked about that. So, the recommendations for women with premature ovarian insufficiency and for women with early menopause, which is menopause between the ages of 40 and 45, is to use hormone therapy until the average age of menopause, which would be in your early 50s. The thinking behind this is that we know that this group of women is at increased risk for heart disease and for osteoporosis. And in that particular setting, we think that the potential benefits to as far as preventing osteoporosis and heart disease are concerned, may outweigh the risks of hormone therapy. And, but interestingly, we don't have any amazing data. All the data we have is observational. Nonetheless, we do, in this particular group of women, recommend hormone therapy until the average age of menopause, at least. You don't have to stop at 52 or 50. It just means that's kind of when we want to get you at least to that point. And then the follow-on question to that was like, is there a specific dose that's recommended? And there's not. And there's not even a specific regimen that's recommended in POI. Actually, a lot of times we use birth control pills because women with POI can have unpredictable ovulation at the very end of their reproductive lives, and they can still get pregnant. So that is why our recommendations are what they are. And then I'm seeing lots and lots of bone questions today. So I actually have gotten at least 3 questions, and then there's one in the chat already about bone health. So let's dive in. Let's talk about bone health. The first question was from a reader who was asking for her mom. Her mother is 68, and she never took HRT. Unfortunately, she was in that group of women who were going through perimenopause and menopause in the years when, we were much more restrictive about prescribing hormone therapy. And now she's been diagnosed with osteoporosis in her 60s. Super common. about 50% of women over the age of 50 in the United States have been diagnosed with osteoporosis, and that's actually probably an underestimate. Many of those women are white, and while we think that there may be some differences in prevalence with osteoporosis among women of color, we also think that there are differences um, in how frequently women of color are being screened for osteoporosis. And obviously, if you are not screening a group of people, you cannot diagnose them with something. So now we have a woman who's 68. She has osteoporosis. And the question is should she start HRT now? And even though hormone replacement therapy has been shown to reduce the risk of osteoporosis, there's actually no indication to use hormone therapy to prevent or treat osteoporosis, except in the situation we were talking about before, which was premature ovarian insufficiency. And we do know one of the things that we learned with the Women's Health Initiative was that starting hormone therapy in women who are more than 10 years past their last period or over the age of 60 does seem to increase their risk for cardiovascular disease and maybe also dementia. And so we really don't recommend starting hormone therapy in most cases, in the vast majority of cases, once women are more than 10 years out from menopause, which at 68, this mother almost certainly is. And so in that case, I would say no, we would not recommend hormone therapy. We would recommend treatment, and there's a number of fantastic treatments for osteoporosis. I think people love to hate them, but they are really quite effective. The next question was about bone loss with SSRIs. So SSRI use is incredibly common. They're effective for treating anxiety, depression, and some other psychiatric disorders, um, including OCD. They have also been studied for some other uses. SSRIs have actually been studied for the treatment of hot flushes and night sweats. And for a minority of women, they are fairly effective, but for most women, they're not effective for treating menopausal symptoms. But nonetheless, they are a widely prescribed group of medicines. And so the question was, how to think about the bone loss that has been associated with SSRIs. So there have been reports that women who have taken SSRIs are at increased risk for bone loss. There is some conflict in the data around where that bone loss is most pronounced. So, what type of bone SSRIs are most likely affecting? Um, and and there are some positive theories about how SSRIs might be affecting bone loss. Um, some thinking that they act directly on the bone building cells to inhibit their activity. So you get bone breakdown, but you don't get as much bone building in response to that breakdown, and that leads to weaker bone. Um, so when you look at the data, some studies say you get bone loss in the hip, which is primarily a type of bone called cortical bone. Other studies say that you get more bone loss in the spine, which is more of the bone in the middle of the bones called cancellous bone. Um, and and it turns out when you look at meta-analyses, what you see is that where the significant loss is really in the spine. However, I think you have to interpret these studies pretty carefully. First of all, the participants in these studies are people who are taking SSRIs and who are older. So if you're a woman in your 40s or 50s and you're taking SSRIs, this is not the group of women who are seeing bone loss. It's really in the post menopausal years that we see bone loss. um, with SSRI use. Other thing I think you have to be really, really careful about is thinking about who these groups of people are. So in one meta-analysis, they had they looked at 11 different studies, and they found 7 studies that were cross-sectional studies, which is a type of like a study where you look at people right in a moment, and the other 2 studies were cohort control studies. None of the 11 studies were randomized control trials. You can understand why that might be the case because you wouldn't randomize people to take an SSRI or not take an SSRI if they didn't have a psychiatric diagnosis that needed treatment. And you wouldn't withhold treatment for a psychiatric diagnosis to see if the treatment to see if the treatment caused a side effect like a loss of bone mass. And so we're only ever going to have observational studies. And the problem with that is that inherently, the people who are taking SSRIs are different than the people who have not taken SSRIs in really important ways that might affect things like how active they are, how much bone mass they built to begin with, how much weight bearing exercise they're doing, what other medications they might be taking. And so, really, these 2 groups of people are very, very different. And even though we have a purported mechanism, I think you really have to think about why, how this might be interacting. And I think we have to be a little careful in the interpretation of this data. So, while I would say, lots of people get put on SSRIs in an acute moment of crisis and then they're left on them, sometimes for many years. Some people need to take SSRIs chronically. If the benefits outweigh the risks, then I think the answer there is clear. But some people probably after that acute, uh, you know, situation has passed, um, it would, many people could potentially wean down or come off of their SSRIs. And so that would be a consideration. The other thing to note is that we lump all SSRIs together in this case, but some SSRIs seem to have a bigger effect on bone density than others. So if you're going to say that it's the SSRI that is causing these changes in bone density, it is fluoxetine, which is Prozac, which seems to have the biggest effect on bone density. And sertraline and escitalopram, which are um, Zoloft and Lexapro, those medicines are much less associated with these bone changes. And so I think that is important to recognize. And then Eileen had a question about K2 um, with vitamin D. So here we're talking about supplements that are meant to support bone health. So there's a slew of supplements that have been looked at for bone health. Typically, we talk about calcium and vitamin D. Um, but there has been a growing literature about taking K2 with vitamin D. It is not really been incorporated into the guidelines at this point because there's not enough data to really say that it significantly impacts bone health to add K2. But what I would say is it's not going to hurt to add K2 to your vitamin D um, if you have low bone mass and low vitamin D. So the current recommendation is that all women over 55 get 1,200 milligrams a day of calcium. That calcium can come in the form of food and or a supplement. What I usually tell people is that most people eating a relatively healthy diet are getting about 600 milligrams a day pretty easily. So your yogurt in the morning has 300 milligrams of calcium. You may be getting some other dairy throughout the day. There are lots of non-dairy foods that contain calcium. So if you're getting about 600 milligrams of calcium from your diet, you can then focus on getting 600 milligrams as a supplement. Routine vitamin D supplementation is actually not recommended. It hasn't been shown to improve bone density or reduce fracture risk. But if you have low bone mass or osteoporosis and your vitamin D is low, then there's evidence that we should replete your vitamin D to help um, treat the low bone mass, which is what we now call osteopenia, or osteoporosis. And so then if you're taking vitamin D, you would potentially want to add the K2 to it, although the evidence for that is not nearly as clear. Um, Thank you to everyone who has joined us. I'm Dr. Gillian Goddard. I'm an endocrinologist and the author of the Savvy Patient Substack. And today I am answering all your questions about women's hormonal health. I have a few more questions that people submitted in advance of today's Ask Me Anything. But if you have a question that you would like for me to answer today, please go ahead and put your question in the messages below, and I will get to as many as I can. Thank you so much for joining me. So, our next question is about skin. Um, what happens to skin when we are going through perimenopause, and what can we do about it? So, um, when when we exist in the world, gravity is acting on us. We actually need it to not just be a lump. We wouldn't exist without gravity. So, as much as we may not always like it, gravity is important. But it is something that our skin has to work against over the course of our lifetime. Um, when we're young, our skin is very elastic and resilient. And the reason for that is both because it's high in moisture, and it's got a lot of collagen. Collagen, I like to think about collagen as like a scaffold in our skin, that the actual skin cells kind of sit within that scaffold. And um, when our estrogen levels begin to drop in our 40s and 50s, we lose collagen everywhere. There's collagen all over the place. We lose collagen in our bones. We lose collagen in our skin. We lose collagen in the mucosa that lines our vaginas. And this results in a lot of the symptoms that we see in the perimenopausal years. We also lose moisture. Um, and so when you lose moisture and you lose collagen, the skin becomes less resilient. It doesn't bounce back from from stretching, pulling, facial expressions, the way that it did when we were younger. Um, the other thing that happens that can accelerate this process is that we know that ultraviolet light also breaks down collagen, and can thin the top layer of skin, which can lead to even more breakdown. And if you are someone like me who grew up in a very sunny climate, my grandmother moved to Arizona in 1927, and there was no sunscreen, and there was a lot of sunshine. And you could see as she aged on her arms, her skin got very thin, it tore easily. That's all from a loss of collagen, not just from aging, but also from photo damage. So, What can we do about this? The first thing is we can protect ourselves from photo damage. Every dermatologist I know talks about SPF all the time. That doesn't just mean when you're out in the sun, it means that you should be wearing SPF every single day. Um, and we can, and so we can protect ourselves from ultraviolet damage to our skin. So that's the first thing. And you can start doing that now, today. Hopefully, you've already been doing it. Our kids are like very well versed in this. They've never had a sunburn practically. So that's great. But there's a couple things you can do to build back and support the collagen that you do have. So one is retinols or retinoids. So these are in lots of different products. That are available over the counter. Tretinoin is a prescription version of this. These were originally developed to treat acne, but one of the things that they do is stimulate collagen production in the skin. They also help the skin hold in moisture. And so I would definitely recommend if you're looking to help your skin keep the collagen that you have and maybe build some new collagen, that starting with a retinoid or retinol would be a great idea. You can see your dermatologist and they can prescribe you one, or you can try one of the many things that are available over the counter. A dermatologist friend of mine always recommends the SkinCeuticals retinol, which unfortunately doesn't come at a super affordable price point, but she has said she really feels confident that it actually contains what it says it does and seems to be very effective. They have 3 different doses. So you can like start on a low dose and build up. The third thing that has actually been shown to be beneficial is taking collagen. Um, this is not going to be as effective as a retinoid or retinol. This is going to be like an add on to all the other things that you're doing. So, there are studies of both bovine collagen and marine collagen. Bovine collagen comes from the connective tissue of cows. It is a byproduct of the meat processing process. And basically, it's broken down into a powder. Marine collagen is from the connective tissue of seafood, sea life. A lot of it comes from large fish. So tuna is a big source of marine collagen. But again, it's a byproduct of the processing of the fish for eating. And so the one nice thing in both of these cases that we're using kind of the leftovers from a process and utilizing them for something else. It's sold as a powder, and usually you need a hefty dose every day, so a big volume of powder. The collagen I use is a bovine collagen, and you have to use 4 tablespoons a day to get sort of the recommended amount. But you can put it in anything. Bovine collagen doesn't taste like anything, and so you can put it in coffee or your any sort of liquid. Um, and what taking collagen has been shown to do is actually reduce skin wrinkling, improve skin resilience, and improve hydration. But again, I feel like it's like the icing on the cake, but it's not going to give you the same results that sun protection and retinol are going to give you. So that's skin. I wish I had a better solution to, protecting skin from gravity, but unfortunately, I don't. Um, all right, we have a question here. I'm a premenopausal woman, 37, and only learned about perimenopause. Well, welcome. You're in luck because you learned about it probably before you are experiencing it. So one of the question was, what should you expect? And are there things that you can do to head things off? So, what you should expect is a process that starts in your very, very late 30s and or early 40s. and progresses in a fairly organized way through your 50s. So the stages of the perimenopausal transition are the late reproductive stage, which is sort of like a bridge between your peak reproductive years and perimenopause. This is where women start to see some changes in their periods. Actually are still regular, but they can be a little closer together. PMS can be worse. Some women develop PMDD during this time period. And about half of women will enter the late reproductive stage between the ages of 35 and 45. So you may already be in the late reproductive stage, or you may be about to get there in the next 5 to 7 years. The next stage is early perimenopause. Early perimenopause is defined by having irregular periods. So when your periods become irregular, that's when you're in early perimenopause. Irregular is defined as a period that is shorter than 21 days from the first day of one period to the first day of the next, longer than 35 days, and varies by more than 7 days from one cycle to the next cycle. So if you're having a 24-day cycle, then a 45-day cycle, then a 32-day cycle, that is an irregular period. In early perimenopause, even though your periods are irregular, you are still getting a period every um at least every 60 days. The late reproductive stage and early perimenopause can go on for a very long time. This is probably the largest chunk of the perimenopausal transition. And in fact, this is the one place where we don't see people kind of evenly march from one stage to the next. About half of women, according to the Seattle Women's Health Study, about half of women will actually seesaw back and forth between the late reproductive stage and early perimenopause. After early perimenopause is late perimenopause. Late perimenopause is when you are starting to get periods less frequently than every 60 days. So once you are going more than every 60 days without getting a period, you are in late perimenopause. And once you go more than 60 days without having a period, it is highly likely that your last menstrual period will be between 1 to 3 years away. That's a big window, and it's not a hard and fast rule, but it's an estimate. So once you go more than 60 days without a period, it is likely that your last menstrual period will be in the next 12 to 36 months. Once you have your last menstrual period, you enter early menopause. And early menopause is broken into two chunks. There's the first 1 to 3 years after your last menstrual period, and then there's the next 3 to 5 years. So early perimenopause lasts usually it's most of the way through people's 50s. Um, and then after early menopause is late menopause, and late menopause is everything thereafter. So when we look at studies, it looks like women are most symptomatic with the traditional symptoms of menopause and perimenopause. So hot flushes, night sweats, sleep disruption, brain fog, aches and pains, mood changes, irritability. These symptoms tend to peak during late perimenopause and that early chunk of early menopause. So in those years immediately surrounding your last period. But you can develop symptoms as early as the late reproductive years, and some women will have symptoms even into late menopause, although that is fairly unusual. So really what you are looking at is sort of a 15 to 20-year period where your reproductive life is in flux. And that is the perimenopausal transition. The things that you can do, I mean, a healthy lifestyle is always going to be great. Having good sleep habits is really important. And I also think just tracking your periods and tracking your symptoms can be really helpful. Um, when I was first in the late reproductive stage, I started having really bad migraine headaches. I had never even gotten migraines before. It was completely new. And it took me a while to actually take the time to track them. One of the big, non-secrets of the world is that doctors are actually terrible patients themselves. Um, and when I finally did, it was very clear that my headaches were hormonal headaches and that this was a new symptom. And I think that one of the issues um, is that we don't always recognize that our symptoms are related to our hormones, especially when our periods are still regular. And we often go to the doctor and say, I'm having these symptoms and I think I'm in perimenopause. And the doctor says, well, are your periods regular? And if you're in the late reproductive stage, you say yes. And they say, no, you're not in perimenopause. And they're like, have a nice day. But actually what we should be doing is naming that stage for women so that they can understand what it is. And then, and of course, helping them manage their symptoms. Because ultimately, um, the name the name can be helpful because it gives people a sense of like, oh, this is something people go through and this is what it is. But also treating the symptoms should really be um, our number one goal. To that end, I'm going to wrap up with a question that I've been getting a lot lately from all of you and from patients in my office. And this is this idea that people are having perimenopausal symptoms in their 30s. So I think when we're talking about perimenopause in our 30s, we need to be a little careful. Certainly, some women will enter the late reproductive stage in the latter part of their 30s, primarily after age 35, but some people a little earlier. And certainly, there is a small subset of women who will experience premature ovarian insufficiency, which we talked about at the top of this session. Um, and early menopause. But those women who experience premature ovarian insufficiency are a minority and they should be treated, but it is unlikely that you are one of those people. By the age of 40, less than 1% of women are diagnosed with premature ovarian insufficiency. So it really isn't all that common. Um, and so I think we need to be a little careful about this. Earlier in 2025, a study came out that I think sparked a lot of this conversation about women having perimenopausal symptoms in their 30s. Um, I wrote a little bit about this, but basically, what this group did is they gave the menopause rating scale, the MRS. Somebody spent time coming up with that acronym. They gave people that scale, which is a scale for rating perimenopausal symptoms. It has been validated in women age 45 to 60. It has not been validated in younger women. But they gave that scale to women in their 30s and asked them if they had these symptoms. The MRS is broken up into three different sections. There's vasomotor symptoms, which is like hot flushes, night sweats, those types of symptoms. There's psychosocial symptoms. This is brain fog, anxiety, depression, irritability. And then there's genitourinary symptoms. So vaginal dryness, vaginal atrophy, urinary tract infections, painful sex. And so what they did is they gave younger women this MRS, the women, and they said, aha, there's all these women and they're having all these symptoms in their 30s and we're not telling them that they're in perimenopause. But when you look at the data, the women who are who are scoring high on the MRS in their 30s are scoring high predominantly in the psychosocial section of the test. They are not reporting hot flushes and night sweats by and large. They're not reporting vaginal dryness and pain with sex by and large. They're reporting depression, anxiety, brain fog. Um, and I think we need to be really cautious about interpreting that data um, as saying that women in their 30s are experiencing perimenopausal symptoms because when we tell people, because of one of two things. One is we tell people their symptoms are because of perimenopause, they dismiss their symptoms and they don't get treatment for their symptoms. Number two is, and I've seen this a few times in my practice recently, women get started on hormone therapy, not on a birth control pill, on a hormone therapy that we usually give women in their 40s and 50s because they're saying that they're having perimenopausal symptoms and they're largely mood symptoms. And the hormone therapy is not helping. And the reason the hormone therapy is not helping is because their symptoms were probably not perimenopause to begin with. I think we can all agree that there are lots of reasons why we all might be anxious, depressed, irritable, not so focused. And those things may be physical, they may be biochemical in our brain, they may be situational. People may be living in very stressful situations. I would argue that right now, living generally is a really stressful situation. And so I don't think that we are doing women a service by telling them that these symptoms are perimenopause. And so I'm so glad you guys are asking these kinds of questions and asking sort of what to expect because the ultimate goal is to recognize people's symptoms, whatever they are and whatever they're due to, and try to pinpoint why people are having symptoms and then treat them effectively. And so I think that if we're explaining, if we're trying to say that symptoms are due to something that they're not, um, all we're doing is impeding women from getting the treatment that they need and deserve. Um, So, on that cheery note, I think we will wrap things up for today. Thank you to everyone who joined today. As always, you can find me at The Savvy Patient on Substack. I am at The Savvy Patient on Instagram. And you can always send questions for the newsletter, for an Ask Me Anything. You can always send your questions to ask at thesavvypatient.com. It's been great to see you guys. I'm putting together the plan for February, and I hope that you will join me here again. Have a great day.